Hello, my topic is Pembrolizumab plus chemotherapy in metastatic non-cell lung cancer. My name is María Belén Vera González. Definition is first line is therapy for advanced non-small cell lung cancer and SCLC that last targetable mutation is platinum-based chemotherapy among patients with a tumor proportion score from programmatic ligand 1 PD-L1 of 50%, or greater. Pembrolizumab has replaced cytotoxic chemotherapy as the first-line treatment of choice. The addition of pembrolizumab to chemotherapy results in significantly higher rates of response and longer progression-free survival than chemotherapy alone in a phase 2 trial.
We conducted a randomized phase 2 trial in advanced non-squamous non-small cell lung cancer looking at standard chemotherapy, PEM-carbo, pemetrexed carboplatin combination with or without pembrolizumab. So one of the new PD-1 inhibitors that already has an approval in the second-line setting in individuals with 50% expression or higher of PD-L1. Our trial randomized roughly 123 patients. They were stratified but not selected for PD-L1 status. So any PD-L1 status was allowed. That PD-L1 status was blinded to the individual participants and their physicians. And the primary endpoint was response rate, and if that was positive, then progression-free survival. And in fact, we hit both primary endpoints. Response rate was nearly double, 55% compared to 28% for the control group. And we saw more than a 4-month improvement in median progression-free survival from 8.9 months to 13 months for the pembrolizumab combination. Survival currently is virtually identical. It's still very early. Plus, there is crossover in the control arm to pembrolizumab. So at 6 months, 92% are alive in both arms, and 1 year, 75% are alive in the pembro arm, 72% in the chemotherapy control arm. In general, the combination regimen, pembrolizumab and chemo, is very well tolerated. We do see a somewhat higher rate of overall toxicity in grade 3 and 4, but well within acceptable limits. 26% versus 39%. There were no differences in treatment discontinuation rates or deaths on study. There's really two different answers to that question. In the context of our trial, it took all comers. They had to be non-squamous, but it could be PD-L1 negative, 1 to 50% or 50% or higher. The benefit was similar for response regardless of PD-L1 status. Of note, those who had 50% or higher did have a higher response rate, about 80% compared to the mid-50s or lower 50s for those with lower levels of expression. The control group that had PD-L1 levels higher than 50%, their response on standard chemo is in the mid-30s, so 80% versus mid-30s. It's a very different issue for those who are PD-L1 positive in the context of Dr. Reck's trial that compared Pembro to standard chemotherapy. There, we observe a response benefit, a progression-free survival benefit, and most importantly, an overall survival benefit, despite crossover. So the crossover is included in that trial as well, and they still observed a survival benefit. So I think as we go forward, we're going to separate out those who are PD-L1 positive 50% or higher from the rest. And if we do the math, the PD-L1 high expressors are roughly 25 to 30% of the overall population of non-marker, non-small cell. It's getting very complicated.
Application in medicine. Lung cancer is the leading cause of cancer-related death worldwide. Platinum-based chemotherapy with or without maintenance therapy and subsequently followed by second-line cytotoxic chemotherapy is standard treatment for mixed patients with advanced non-small cell lung cancer with a median survival of approximately a year.
My presentation at ASCO 2018 plenary session is on Keynote 42, which is a clinical trial comparing pembrolizumab as a single agent versus chemotherapy as a single modality in patients with non-small cell lung cancer with both squamous and non-squamous histology who did not have EGFR mutations or ALK translocations and who had not yet received treatment for advanced or metastatic disease. In this trial, we randomized 637 patients to each arm, and we had overall survival for the whole trial population and for the groups with 20% and above and 50% and above PD-L1 expression using the tumor proportion score. And of course, the whole trial population had a tumor proportion score of 1% and above. We did not enroll patients without any PD-L1 expression, and what we did show is that overall survival was better for the whole trial population as well as for the groups of 20% and above and 50% and above. In addition to that, we also looked at toxicity for all patients, and patients who received pembrolizumab had fewer adverse events than patients who received chemotherapy. When we looked at severe adverse events graded between 3 and 5, we saw that only about 17-18% of patients with pembrolizumab had those events versus approximately 40% of patients who received chemotherapy. In summary, this is a positive study that gives us a new option in the treatment of patients with advanced non-small cell lung cancer who have disease that does not have EGFR mutations or ALK translocations and that expresses, with tumors that expresses PD-L1 at 1% and above versus old standards as chemotherapy. And of course, now we have to place this in perspective with the new options that we also have of using immunotherapy in combination of chemotherapy. And this is something that we're going to be discussing here at ASCO. Who are the patients that would benefit and would probably be better candidates for immunotherapy alone, and who are the patients that need that combination of chemotherapy with immunotherapy. So we still have a lot of work to do, and I hope to see you guys again soon at World Lung, ESMO, and ASCO next year.
Pros: treatment of stage 0 non-small cell lung cancer, neither chemotherapy nor radiotherapy is necessary, so treatment with pembrolizumab Keytruda may be an option as a first treatment. Treatment can be done by radiofrequency ablation may be another option if the tumor is small and is in the outer part of the lung.
The excitement now is with the approval of a regimen of chemotherapy, in this case carboplatin and pemetrexed, with pembrolizumab. So this is a regimen that's already been explored in a study called Keynote 021G. Dr. Corey Langer presented and published these data earlier in the year. And now we have an approval in the first-line setting for patients really regardless of PD-L1 status who just have advanced disease, newly diagnosed, and of course non-squamous, non-small cell lung cancer. So this is a big step forward. We had pembrolizumab for about a quarter of our patients with PD-L1 high expressing tumors, and now we have a regimen that's available for really all patients regardless of PD-L1 expression. So this is a big step forward, and probably the first of several we'll see over the course of the next several months or years where we're going to be seeing other chemotherapy regimens with other checkpoint inhibitors, atezolizumab combinations, nivolumab combinations. So more to come, but this is a big step forward in the care of patients with lung cancer.
Cons: Pembrolizumab showed modest toxicity. Treatment-related serious adverse events of grade 3 or greater severity were observed in less than 10% of patients, a percent that is lower than that anticipated with chemotherapy.
I have the honor of presenting for the Canadian Cancer Clinical Trials Group Investigation on New Drug Committee the IND 226 trial. This is a trial of quadruple therapy for first-line cancer in general. It's a phase 1 all-comers clinical trial with platinum doublet chemotherapy, adding on 2 different immuno-oncology drugs, durvalumab, which is a PD-L1 inhibitor, as well as tremelimumab, a CTLA-4 inhibitor. Today's presentation was focusing on the pemetrexed cisplatin non-small cell lung cancer cohort, so a subset of the larger clinical trial. The concept behind it is we've seen benefits of obviously chemotherapy over the years, and we're now seeing benefits of immunotherapy, but not all patients actually live long enough to be able to get to some of these subsequent therapies. So we're looking at trying to bring some of the therapies in earlier, and we've seen benefits of immuno-oncology doublets and immuno-oncology with chemotherapy. So this is the first trial that has actually presented quadruple therapy with platinum doublet plus a CTLA-4 inhibitor as well as a PD-L1 inhibitor.
Then is completed in Ecuador. In Ecuador, the study is completed by the Ecuadorian Institute of Statistics and Census (INEC). Showed that in 2013, malignant tumors caused 8191 deaths. To this is a date that, according to the Minister of Health, mortality for cancer in Ecuador for the male population occurs most frequently from cancer of the stomach, prostate, trachea, bronchial lung, liver, bile, blood, and colorectal. For the female population, mortality is due to cancers of the stomach, severe breast, and liver. Given these scenarios, immunotherapy treatments are an alternative. Surgeon oncologist Ralph Olives Peliosilis in France points out that it is one of the most far-reaching strategies in the fight against cancer. He adds that this technique is already used in the country. Conclusion: in patients with previously untreated metastatic non-squamous NSCLC without EGFR or ALK mutations, the addition of pembrolizumab to standard chemotherapy of primitives and platinum-based drug result in significantly longer overall survival and progression-free survival than chemotherapy alone.
My name is Anthony Rivas. I'm a professor of medicine at UCLA, and I'm the director of the tumor immunology program at the Johnson Comprehensive Cancer Center. The original objective of this clinical trial was safety of a new drug called pembrolizumab. As the study was conducted, the objective changed to assessing early evidence of anti-tumor activity. This paper reports on a phase 1 expansion of pembrolizumab, a first-in-class anti-PD-1 blocking antibody that unleashes immune responses to cancer. This clinical trial started as a cohort of patients with metastatic melanoma being treated with pembrolizumab at a certain dosing regimen of 10 mg per kilograms every 2 weeks. After the first 30 patients were entered, there was evidence of anti-tumor activity in a significant number of them, So the study was expanded to up to 655 patients to better assess the dosing regimen and anti-tumor activity. In this clinical trial, pembrolizumab had an objective response rate of 33%. This is in all patients entered in the study, which tested 3 dosing regimens of pembrolizumab. There was no difference in the dosing regimens. In patients who were previously untreated with metastatic melanoma, the response rate was 45%. Out of the patients who had an objective response, the majority of them maintained the objective response. At 1 and 2 years, 75% of the patients continued to respond. The median overall survival in the whole population was 23 months, which compares favorably to what was known of the median survival of metastatic melanoma to any other prior therapy. 14% of the patients had grade 3 or 4 toxicities, which are clinically significant adverse events. The majority of those side effects were managed by temporarily stopping the treatment or giving symptomatic treatments. Only 4% of the patients had to stop the therapy because of adverse events. This clinical trial led to the approval of pembrolizumab based on a breakthrough status designation by the Food and Drug Administration. The first approval was in patients who had previously progressed on prior therapies, including ipilimumab, and afterwards it was expanded to patients with metastatic melanoma with any prior therapy. After this phase 1 expansion trial, the next steps were a phase 2 and a phase 3 clinical trials. These clinical trials have already been conducted and have led to the approval of pembrolizumab across the world for patients with metastatic melanoma.
Finish. Thank you. See you.